Dr. Janeane Walker, Director of Faculty Development and Educational Outcomes. Thanks for joining for our podcast today. And today we're going to be focused in on simulation. So I'm joined by a great group of panelists, and I'm just going to have them go around the table and introduce themselves. We'll start with Jim.
Hi, I'm Jim Rinehart. I'm the Director of Simulation and Clinical Skills for Northeast Georgia. And my background has been in simulation education for about 20 years now.
Oh, wow.
I'm Nicole Beringson. I am the manager for patient simulation here at Northeast Georgia, and my background is nursing with management and education for the last 28 years.
Oh, wow.
And I'm Corey Hill. I am the standardized patient educator, and my background is also nursing. I have about 15 years of nursing experience, with about 10 of that being in education.
Excellent. So we're going to cover a lot of topics today, but I first want to start off with faculty training. As each of you bring a wealth of experience into simulation education, can you start by sharing a key moment or project in your career that significantly shaped your approach to faculty development as it relates to simulation?
So for me, I started off after 9/11 with SIM. We purchased a bunch of mannequins simulators for doing bioterrorism training. So we had 4 high fidelity, the computerized humans. And then as we went in to start utilizing it, finding out that no one really had any idea. They thought it was a big doll or like a CPR mannequin. And then when I would go through, here's everything it can do, physiology, all the things you can do with it, everyone kind of had that blank stare. And I knew I had a whole different avenue I needed to go down, which outside of the simulator, I had to work on getting people trained on how to use it so that they would follow pedagogical principles as we went through to get the learning outcomes that we were hoping to get. And then as I went into other careers, University of Arizona and Midwestern, finding the same thing. So that's always been one of the primary things that we focus on when we're implementing simulation is getting the faculty comfortable and them understanding the objectives that they need to cover and how we can do that following the good learning principles.
Thanks for bringing that up. And when we think of some of the common challenges faculty face, what are they when they're transitioning to a simulation-based type curriculum or teaching? How do you address those issues when faculty come in and they've never done simulation before? Are there any particular common challenges that you see that any of them might experience?
Yeah, so I think a lot of it is just lack of experience with simulation in general. Simulation equipment, technology, standardized patients, task trainers, as well as how to bring simulation into their current curriculum that they're developing. So kind of the logistics of things. I think those are some of the challenges. And then as well as kind of getting away from more of the traditional teaching methods and seeing a simulation as a teaching modality.
And one other thing, can you share maybe some examples of any workshops or resources that significantly impacted our faculty? Like, was there a particular education everyone was like, you know what, we probably need to utilize this approach to teach our faculty to learn something different? I think you guys did something surrounding POCUS. Do you want to share a little bit about that?
Sure. So each program kind of has its own specific needs that we try to encompass. With CME, that would be the milestones. What skills does that individual program have? And so then once we kind of get an idea of what those clinical skills need to be and communication skills bedside, we put them into the sim and then meet with the faculty. And the best way we do first is for them to observe a sim, because many faculty haven't had the experience of what we have, this robust sim kind of set up for here at Northeast Georgia, and a lot of them are coming from a background of not ever done sim before. So first we'll start off with come and watch it, and we'll go through, here's what's going on, here's how we set it up, and then go through the whole thing and get them beyond that impression that it's a simulation. Let's go to that next step and say, make it as real as possible that fits within the learners, where the learners had. Now, PGY1 is different than a PGY3. So we need to learn that they're not going to jump into a full-blown critical care scenario for an intern. whereas a PGY3. So putting them through that kind of a role, and then we can step back and say, okay, what are your ideas? And can we put your ideas into a simulation? So they start to learn our foundations as we build it from there.
So when new faculty come over, do you give them a tour of the simulation center? Can anyone just share what our simulation center looks like here at Northeast Georgia? How many rooms you have, classrooms, debriefing, kind of just set us up. You'll give that one to you, Nicole. Like, what is our environment? Because I'm thinking as faculty, as they come over and they've never done simulation before, and now we're going to show, hey, here's our sim center. What's your approach when you're taking faculty around?
So we love to tour our new faculty. We have our sim center. Our main sim center is at Rinehart Park. So we have 10 sim rooms and 3 debriefing rooms. And in that center, we also have classroom space as well and a procedural space. We also have a sim lab at the main campus, hospital campus, which is just procedural based. So you have all of your task trainers, like your central line trainers, your lumbar trainers, etc. But when they come over to Rinehart Park, we tour them. We show them all of our equipment. So our mannequins, what do our rooms look like? What can we do? We talk about what is their vision for their education for their residents? Is there something that they really would like to focus on? We also ask about their past experiences, like what have you done for simulation in the past? Because that kind of formulates what we do with them in the future, or kind of work with them with their vision for those residents. So we just tour them around. We show them all of our equipment, and then we talk more about our program, like how do we develop our program. Our sim center, we're very fortunate because we do have a large staff with sim. So each program has a primary educator that they work with, and that's kind of their person that they pair up with, that they talk to, that they share their vision with. And then we build that vision, and we also build that trust. So we're building that trust with the faculty. So we're able to have those honest conversations of what do you need help with? What do you feel like you want to grow with? What can we grow? What can we grow your program with? So those are those honest conversations that we start building as we build their trust with them.
When I started in simulation, it was all about the mannequins. When I came here, it was something called standardized patients. Corey, can you tell us a little bit about our standardized patient program, but more specifically, what role do standardized patients play in medical education?
Sure. So first of all, a standardized patient is usually an actor or an actress that is coming in portraying that patient or that character during a simulation. So we have about 40 standardized patients right now, pretty diverse from 18 to I think like 78. So what we're doing with standardized patients in medical education is they're coming in during our simulations. You've got a live patient in front of you during a simulated event, and our residents are having to learn communication techniques and skills, having to learn how to give bad news, learning how to get consent and prep them for a procedure or a skill that they're going to have to do. And it really makes that simulation more realistic. Instead of having that mannequin, that static mannequin that lays in the bed, they have this person that they have to interact with. And I really think that that helps from a clinical standpoint and patient satisfaction as well.
So how are your standardized patients actually trained and selected to be part of the program?
Sure. So we do have quite an extensive interview process. They apply, HR kind of goes through them. They come in, they do a group interview. It's almost a panel interview. And in that, we talk about what the standardized patient program is, if they're comfortable with having someone assess them, and those types of things. And then we actually make them do some role playing. So we give them a script, and they have to then role play that character in front of us. After that, we will kind of narrow down the interviewees that come in and have them come in for a second interview. And here they'll have another standardized patient. So one of our experienced SPs coming in, and they'll be doing 2 different scenarios. And they go in, they have about 30 minutes to learn the sim. And then they go in with that experienced SP, and they have to role play it all the way through. So that way we can see how they interact with someone else, how would they portray this character, as well as kind of just their main mannerisms. Can they really put themselves in that perspective of the patient?
The key to this is that along with that, we'll look for specific demographics within our SP pool. And so that is the other unique part of the SP. So if we do one on transgender. So we'll have a subject matter expert who deals with that, and it would be like for us, Dr. Bonmiller and some of her patients, but then teach the SPs, or if we need a different ethnicity, and making sure that we're drawing from our community, not just the actors and actresses, but they fit the demographic we need to fulfill this learning need. And the idea behind that is then every resident, every nurse that we're training gets that same experience. And that's something that we don't get out into the clinical field. And so that's the other part of simulation, especially with the standardized patient program, is I can recreate the same scenario over and over again. And important training the SPs that they can follow that, but with that demographic or whatever, so we know every learner gets exactly the same, so we can meet these learning objectives rather than hope, happen chance that everyone's going to get it out on the floor, and we know that doesn't happen. So that's the other part, the critical part of SIM with the standardized patients is getting, giving bad news, which is really, none of them want to have to do that. But in that safe environment with an SP, and then you have another SP playing family, and they can put all of that together and start learning their way of communicating. And then we have faculty come in and help them afterwards for the debriefing, which we'll talk about in a little bit. But
well, thank you for that segue. That's actually where we're going to go, talking about debriefing and reflective practices. So what strategies are most effective for training our faculty to conduct debriefings and really to promote that deep learning amongst our residents? So is there something that you have in place? What strategies do we use currently? Or is there anything in particular that you would like to see this program grow to for our faculty as it relates to debriefing and reflective practice?
You guys are going to... That's all they had to turn.
Well, I know the other day you guys asked me to come and assist with some debriefing. I wasn't the brainchild behind that. I was just like a person in the room to help with the debriefing and reflective practice when we were teaching the chiefs.
Right. And with debriefing, there's a cadre of different modalities out there, pearls and a lot of the other ones. So we've adopted pearls within ours, but at the same time, we want it to be adaptable to what's the learning objectives, what level is the learner, and how comfortable are the faculty. So when we do our faculty development with debriefing, it really falls into what is our main core with them is what's the objective, and then having their debriefing follow what the objectives are. Because a lot of times they can get tunnel vision of, if it was a skill they were watching the learner do and they were going down the wrong path, that isn't part of the objective. So bringing them back. So they remember, so that our key takeaways with that we want to build the program is how to provide feedback and debriefing based on what it is they're doing. I'm going to give a different type of debriefing if I'm doing a central line skill compared to if I'm doing an end-of-life communication skill. Totally two different ways of, one's going to be feedback, here's how you did with the skill, proficiency, and one's going to be more debriefing of how did that make you feel, and go through those whole thing, which is what the pearls kind of part does. So we have some videos that we've set up with some of our faculty that we show, and then you guys can add a little bit to what you see with the debriefing.
Yeah, you mentioned pearls. I think that's kind of a framework for them to use to really have open communication during debriefing and really focus more on self-reflection. Self-directed learning. So kind of asking the participant, how did you think that went? I noticed that you paused at this point. Can you tell me what you were thinking then? And letting them kind of self-reflect and answer that question.
Have you found any challenges, and this is not in the notes, so sorry, I'm going to go off cue here. After we've done a simulation and you observe the faculty actually conducting the debriefing, do you go in afterwards or huddle with the faculty person to kind of give them some feedback on what we can do differently in the room? And I know I've seen that a few times. Do you want to share some experiences?
We do. So as some educators, we're in the simulation room with the faculty watching the simulation. So if it's a newer faculty in our facility, we sit with them and there's a debrief guide that we work with them. We have a guide of the simulation and we kind of work with them through the debrief guide. and then they'll go ahead and debrief. And then when they come back into the control room and speak with us, we will give them some of that feedback of, maybe we need to go through the debrief guide, or they didn't meet the objectives, and maybe you could focus on something like that. Or we also talk about, how did the SP do? So if they're doing something with an SP, a simulation with an SP, we start that conversation of, do you have feedback for us for that simulation or for the SP? And so we have that dialogue with the faculty, and then we'll kind of give them some feedback of, maybe ask them, how did that go first? Like maybe use that sentence first when you use that debriefing technique, and let the learner speak. It's more of that reflective experience versus that teaching experience. So debriefing is not for teaching, it's really reflective.
Any other comments that you want to say about giving feedback to the faculty after they've done their own debriefings and that you've experienced?
So something that we're implementing right now with GME with psychiatry is that the PGY3 residents are learning how to debrief with the psych faculty. So they're actually doing a whole course on how to debrief, what does that mean, and then they will be going in, watching and observing faculty debrief in the rooms with our PGY1s. And then they will be going in together as a team to debrief the PGY1s. And then I think that the hope is eventually that once they feel comfortable, that they'll be going in by themselves to debrief as well and assist with those faculty roles.
So it's almost like train the trainers, so bringing them in for our chiefs. Excellent. If you had to give faculty any advice or surrounding debriefing techniques, is there any things that you want to say to them? Any particular tips you want to give them? This will be on YouTube later. Is there any tips you want to share about debriefing, reflective practice? We've talked a little bit about the tools.
Yeah, the key.
Is there something else? What's really the key to debriefing?
One big key is that they've reviewed the sim that they're going to be observing and then providing feedback. And a lot of times, old school is they would, come down from the floor and run a sim and say, what sim are we doing today? And you'd hand it to them. And then the debriefing kind of goes awry at that point because they really didn't know what the objectives were. So we make sure that we will get them the sim prior to it so they can review it if they need to make notes. So really critical is for them to participate in what we call a dry run. So we'll set up, and one of the primary educators or in the team will develop the sim with the faculty person. But then when we get ready before we actually run it, we'll do a dry run and have them come and go through it with us so they can see how it flows. It's really more difficult to do it is if they're coming in and it's a new sim and they've never seen a sim before, and we want them to go debrief because they don't know what the objectives are and they're missing that point. And so the challenges with that is time. Do they have time to do it? And what we're doing to develop it. So as the program grows, it's becoming more and more obvious for us that the faculty really are championing it and helping us get there. And then we find ways to work around it. But I think that's one of them is just the pre-brief side of it, that they're up knowing what the objectives are, what level the learner is, what we've done to set it up for them so they understand how the flow is going to go. Because that would change how I would debrief if I know it, rather than coming in cold and going, I have no idea what I'm doing. And then you're going to pick out what you think is important, but it may not be what we actually want them to be objective.
So what's more important, the pre-brief, the simulation, or the debrief? So if I'm a new faculty person, suppose I want to spend more time here. So is there a balance between it?
All important.
Okay, they're all important. But do we spend more time on one? I'm just trying to think here. For our faculty who are new, suppose they're just like, I'm going to stay out
all
here.
very important.
Okay.
But you really have to set the stage. So your pre-brief is very important. You have to make sure that the learners understand the objectives and what they're supposed to be doing in that simulation. So when you look at a 20-minute simulation, your pre-brief should be about 5 minutes, and your simulation will only last 5 or 6 minutes. And then you have that debrief. You have that 20 minutes afterwards just to, sit back and do that reflective debrief of how did that go? What didn't go well? What did go well? What would you change? Are there any words you would use differently? Especially if you're working with an SP and you're communicating with them, what was your body language? So, when you're talking about simulation, all of it's really important, but it's really important to set the stage first. So you have to have that, then your simulation, and then your debrief. And your debrief is what those learners are going to take away.
And that's the key, and part of that, before we even get to the pre-brief, is just the development stage. And that's, I think, the eye-opener for faculty when we get them in is to understand that one 30-minute sim might have 40 hours of content work into it, doing everything I talked about with the drive run and just development. When we develop a sim, a lot of times they come in and they do what we call on the fly. Oh, I want to run a chest pain.
Yes.
Oh, wait a minute. So we kind of bring it back and we will write it out and then make sure we're doing what's clinically relevant, that it's validated. So all that work that has to go into it to have it validated by a clinician, that we're utilizing best practices and all that flows, and that it fits within, for us at Northeast Georgia, that fits within our system. So we make sure that what we're teaching our learners fit within our protocols and everything. So faculty have to be on board with that and understanding the work that, why we give them a primary educator, because that's what their responsibility is, to work with that faculty to develop that sim. And we have some sims that they put 40 to 100 hours to get one good critical care sim to make sure that it goes down the right path, that we don't have conflicting pathologies that you see a lot of times where I had this really cool case the other day, let's do a sim.
Yeah.
And it ends up not working. So getting the faculty up on that part of understanding the sim process is a huge part of faculty development for us. And then once they get into it, and then I've championed them.